Welcome back. In part 3 of our lecture series, we will take a closer look at different types of outcome measures that can be used in clinical trials. We will use cancer as an example. By the end of this section, you should be able to define some measures of mortality and survival. You should be able to explain and list some surrogate measures used as endpoints in clinical trials and discuss tumor response measures and the response evaluation criteria in solid tumors, RECIST, as an example of composite surrogate measures. Here, we will take a closer look at outcome measures using as an example trials in patients with cancer. The first set of outcomes or endpoints are those of survival and mortality. We may also use surrogate measures which may include biochemical, physical, or physiological markers as endpoints in clinical trials. Finally, we can use patient-reported outcomes, that is, what patients tell us about how they feel. Mortality and survival are very important outcomes in any trial. While they are related, conceptually they are also different. A mortality rate is the number of people who die of a certain cause in a year divided by total number of people at risk. A survival rate is the proportion of people who are alive during a period of time after diagnosis. Let's imagine that there is a cancer for which there is no treatment or cure. The mortality rates would remain constant as there would not be a way to avoid death from the disease. However, survival rates could vary as they would be dependent on when the cancer was diagnosed. Let's say that on average, half of the people with the disease might live for 2 years after they start having symptoms. We would say then that the 2-year survival is 50%. Let's imagine now that we have a screening test that could detect the disease a year before symptoms occur, but we would still have no treatment. In this case, we would have a 3-year survival rate of 50%. As can be seen, the mortality rates would remain constant, but the survival rates would vary according to how early the diagnosis was made. Mortality rates are usually estimated for 1-year intervals. We may be interested in mortality in general from any cause, or mortality that can be attributed to a given cause, and then it is disease-specific. For example, cancer-related mortality, or even more specifically, mortality caused by a particular type of cancer. For example, prostate cancer or breast cancer mortality rates. There are a number of measures of survival that can be used as endpoints in clinical trials. The first one is overall survival. This is the time from randomization to the time of death from any cause. It is the gold standard for demonstrating clinical benefit for cancer treatments. It can be assessed easily and very accurately with respect to the outcome, death, and the time of the event. It should include all randomized subjects, irrespective of other outcomes. It encompasses both efficacy and safety, as death can occur as a consequence of disease progression, but also as an adverse event due to treatment toxicity. The downside of this measure is that it may require large studies and long periods of follow-up, particularly for cancers that are not very lethal. And it may be potentially confounded by crossover if patients change treatment, subsequent therapies, and also by non-cancer deaths. Another measure of survival is disease-free survival. This is the time from randomization until tumor recurrence or death from any cause after treatments given with curative intent. Progression-free survival is the time from randomization until objective tumor progression is observed or until death from any cause, whatever occurs first. An important concept in survival analysis is competing risk. Clinical trials are longitudinal studies in which the outcome of interest is observed over time. If other events occur early on, it may not be possible to observe the endpoint of interest. A competing risk is an event whose occurrence changes our ability to observe the endpoint of interest. For example, in a study in patients with prostate cancer, mortality and 5-year survival might be the endpoint of interest. However, if there are earlier deaths from cardiovascular disease or other chronic diseases which are unrelated to prostate cancer, this could occur during these 5 years. It will not be possible then to observe the endpoint of interest in those who die earlier from other diseases. This mortality risk from other conditions is a competing risk because its prior occurrence makes it impossible to observe the endpoint of interest. Now, before we talk about surrogate measures, let's briefly discuss biomarkers. A biomarker is a characteristic that is objectively measured and evaluated as an indicator of normal biologic or pathogenic processes or as a response to a therapeutic intervention. In clinical practice, biomarkers may be used in diagnosis and staging of a disease or to monitor the response to therapy. In clinical trials, they may be used to explore the effects of an investigational drug. Biomarkers by themselves are not clinically meaningful. A good biomarker, however, should be associated with clinically important outcomes, such as those that matter to patients, and in that case, they can be used as surrogate outcomes. Although a clinically meaningful endpoint would be the desired endpoint for every clinical trial, it is not always feasible. Therefore, a surrogate endpoint may be preferred in some instances. A surrogate endpoint is a biomarker intended to substitute for a clinical endpoint. It is expected to predict clinical benefit or harm, or lack of benefit or harm, based on epidemiologic, therapeutic, pathophysiologic, or other scientific evidence. The use of a biomarker as a surrogate endpoint requires the demonstration of its accuracy and precision. Surrogate measures may reflect biochemical, anatomic, pathophysiological, or physical changes. These may include serum or blood biomarkers, for example, hemoglobin or prostate-specific antigen or PSA. Surrogate measures may also include markers on the surface of cells, for instance, CD4 counts in patients with human immunodeficiency virus or HIV. Surrogate biomarkers also include changes in imaging such as PET scans or MRI. Finally, they can include physical measures such as weight or blood pressure. We will examine now a methodology that is used in trials involving solid tumors. Tumor shrinkage and time to progression are important endpoints in cancer clinical trials. Changes in tumor size require anatomical measurements of tumor size. However, this cannot be easily performed if the tumor is not visible, and therefore imaging biomarkers need to be used. The development of such a strategy requires standard criteria, robust validation, feasibility, and consensus by users. The response evaluation criteria in solid tumors or RECIST was developed by a group of international stakeholders and was initially published in the year 2000, but it underwent subsequent updates. It can only be used for solid tumors and not for hematologic malignancies such as lymphoma. Let's review the RECIST criteria. At baseline, tumors or lymph nodes are designated as measurable or non-measurable. Measurable tumors must be accurately measured in at least one dimension. They must have a minimum size of 10 millimeters by CT scan. CT scan slice thickness must not be greater than 5 millimeters or 10 millimeters caliper measurement by clinical exam. Lesions which cannot be accurately measured with calipers should be recorded as non-measurable or 20 millimeters by chest X-ray. Lymph nodes may be enlarged in many benign situations and therefore have different criteria. For a lymph node to be measurable, the shortest diameter or axis must be at least 15 millimeters. When more than one measurable tumor is present at baseline, all tumors up to a maximum of 5, with a maximum of 2 per organ, are assessed as target lesions. They are selected to represent all of the tumors. The same method and technique of measurement used at baseline must be used at follow-up. Solid tumors may shrink, progress, or remain unchanged with treatment. In target lesions, tumor response may be a complete response in which there is disappearance of all target lesions in response to treatment. However, this does not necessarily mean that the cancer is cured, as recurrences could occur. Partial response, where there is a decrease of at least 30% in the size of a target lesion, is determined by the sum of the diameters in reference to the baseline measures. Stable disease occurs when there is neither enough shrinkage to qualify for partial response, nor enough increase to qualify for progressive disease, with reference to the smallest sum diameters while on the study. Progressive disease occurs when there is an increase of at least 20% in the size of target lesions, in reference to the smallest sum recorded in the study. The appearance of new lesions also signify progression. This is a very simplistic description, and you may want to read more about this from the resources provided. I just wanted to show how using surrogate imaging biomarkers can be utilized to develop an important outcome measure which correlates well with other endpoints such as survival and overall quality of life. What are some strengths in using tumor response measures in clinical trials? This measure usually requires a smaller sample size than using survival as an endpoint. It may also require a shorter follow-up time, since one does not have to wait until death occurs to measure response. Another strength is that this outcome may be measured in a single-arm study because tumor size at baseline is compared with follow-up, and without treatment, tumors will generally progress. Finally, most importantly, patients in a trial are given the opportunity to change therapy as soon as it's evident that there are no benefits from the clinical intervention. What may be the weaknesses in tumor response measures? Tumor response criteria may underestimate treatment effects on endpoints such as survival by failing to adequately capture the duration of the effect. They may also overestimate benefits. This might happen if the response is brief. These criteria do not capture harms or adverse events of the treatment under study. They do not tell us about the benefits that matter to patients, such as symptom control or quality of life, and may not always correlate well with survival, as other factors such as location of the tumor may play an important role. This is the end of this section. We will now go for a short quiz.